we start. Hello, everyone. Thank you so much for joining. We will get started in just a moment and give some time for more people to join. All right. So I think we have a bunch of folks who have joined now, so we will go ahead and get started. So good morning, good afternoon, good evening from wherever you are joining from, and welcome to today's webinar, which is hosted by the Hepatitis B Foundation and the Coalition Against Hepatitis for People of African Origin, also known as CHIPO, at the Hep B Foundation. My name is Beatrice Sovich. I'm a public health program manager at the foundation and manager of CHIPO. And I'm also joined today by Dr. Catherine Freeland, Associate Director of Public Health Research at the foundation. Thank you all so much for tuning in today. Today, we're looking forward to some enlightening presentations focused on the pressing issue of hepatitis B and its integration into broader healthcare systems. This session will feature esteemed speakers from Nigeria and Uganda who will share their unique perspectives and successful strategies for addressing hepatitis B in their communities. As we explore the multifaceted challenges and opportunities associated with hepatitis B, our speakers will highlight innovative approaches to prevention, diagnosis, and treatment within the context of integrated healthcare. And by examining real-world examples and best practices from these two countries, we aim to foster dialogue and collaboration among healthcare professionals, policymakers, and advocates. So we're very much looking forward to this discussion and to gaining valuable insights, engaging in meaningful discussions, and learning how we can collectively enhance our response to hepatitis B on a global scale. So before we get started, we would just like to remind participants that during today's webinar, all audience members are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical issues, please indicate your issue using the chat box and we will address it as soon as possible. If at any time during the discussion you have questions, which we encourage you to share, you can enter them into the Q&A box. Questions will be addressed by our panelists at the conclusion of the discussion. This session is also being recorded, and the recording will be shared with attendees and registrants following the webinar. So just to give a quick overview of the Hepatitis B Foundation. So we are an international nonprofit organization dedicated to improving the quality of life of those impacted by hepatitis B across the globe. Some of our selected programs include a consultation line, a website and social media resources, a storytelling program, public health research, and anti-discrimination efforts. And then just a quick overview of the Coalition Against Hepatitis for People of African Origin, or CHIPO. This is a community coalition co-founded and led by the Hepatitis B Foundation. We are composed of organizations and individuals who are interested in addressing the high rates of hepatitis B infection among African communities around the world. And CHIPO serves as a forum for sharing information and best practices and improving capacity to increase hepatitis B awareness, testing, vaccination, and treatment among highly affected African communities. We currently have over 70 coalition members from across the United States and around Africa. So we will begin by quickly reviewing some of the goals of today's webinar, beginning with the problem, which is that hepatitis B impacts over 250 million people worldwide, making it one of the most common infections globally. The burden of hepatitis B in Africa in particular is among the highest in the world. And among the biggest dangers associated with hepatitis B is that only a small fraction of people who are living with the virus know that they are infected, and of those, only a very small percentage are being properly managed for the disease, leaving many people at high risk for developing liver cancer. There is strong health infrastructure within the African context for many areas, including HIV and maternal health, and there is untapped potential to leverage these platforms for hepatitis B integration, and in this, Africa is poised to be a leader. So today we are really excited and honored to be joined by a number of esteemed panelists. We have with us today Mr. Kenneth Kabagambe, who is the Executive Director of the National Organization for People Living with Hepatitis in Uganda, Mr. Chukwumeka Awocha, who is part of the COVID-19 Therapeutics and Hepatitis Access Program at the Clinton Health Access Initiative in Nigeria. And then also Mr. Emmanuel Olal, who is a Senior Associate of Country Programs at also the Clinton Health Access Initiative in Uganda. And we may also be joined by Ms. Benny Nabitaka, who is a Program Manager also at CHAI Uganda. So each speaker will be delivering a brief presentation, and then we will rejoin together at the end for a panel discussion. We are excited to hear from all of our speakers today, and we're very grateful to them for joining us. So without further ado, we can go ahead and get started. A reminder to the audience members, you're welcome to put any questions you have in the Q&A box throughout the discussion, and we'll answer all of them at the conclusion of the presentations. So we will first begin with Mr. Kabagambe, who will present on opportunities to engage communities for the scale up of hepatitis B activities. So Kenneth, I will pass it to you. Thank you so much.
Thank you so much, Beatrice and the Hepatitis B Foundation for giving me the opportunity to share perspectives from the community in regard to scaling up hepatitis B integration. As you may all be aware, hepatitis B is one of the diseases that are silent, and it is also opened in a way that its funding is not so much as compared to other disease areas like HIV, tuberculosis, and malaria. And therefore, integrating hepatitis B into the existing structures gives an opportunity to, first of all, the people who are living with hepatitis B, because then they will be able to leverage on the systems already in place for HIV. As the world moves to integration, we know that resources are now becoming so small to address all the public health problems across the globe, and therefore an opportunity to integrate some of the diseases like hepatitis B into the existing well-structured systems for HIV provides an opportunity for better patient care management. In Uganda, there is a very good study that was actually conducted in West Nile, a 2-for-1 study that was trying to evaluate the effectiveness of integrating hepatitis B into the HIV program. And it was very clear that this program, this model actually was very important in ensuring that the gaps in the hepatitis B are addressed by the structures already in place for HIV. Much as the hepatitis B community still feels that integrating some of these services into the HIV will broaden the hepatitis stigma that already exists in the hepatitis community. It's important to also listen from their own lived experience and making sure that their feelings are actually taken into consideration while integrating hepatitis B into the existing structures. We know that HIV is well sourced as compared to hepatitis B, but it is also time that we advocate and talk to the developing partners like PEPFAR, the fund that had a huge chunk of funding to most African countries to address the issues of infectious diseases like hepatitis B, HIV into a more public health approach, so that instead of naming clinics like HIV, hepatitis B alone, we should have an inclusive naming that doesn't discriminate on whether you have hepatitis B or HIV, but people should be comfortable to get to these clinics.
Kenneth,
It looks like he may
I
have
think-
dropped off.
Yeah.
Oh, he's
okay.
back.
Oh, perfect. Okay.
Sorry about that. I lost the connection.
No problem.
Yeah, so engaging the community, the patient communities into the integration provides a critical role to sustain, for sustainability, because most of the integration interventions, if we don't actually consider patient organizations and the patients themselves, then the efforts will not be sustained and issues of stigma will continue to propel. And so it is very critical that as we advocate for integration of hepatitis B into the existing programs, we become careful on how we integrate the patient voices and lived experiences. Also involving the patients or the communities into research, clinical research, aimed at improving patient care is very critical. In most cases, we see that even when the programs are being conducted or research, the communities are not actually involved in some of these interventions. And so that brings a gap of evidence, especially when the community organizations, the patients are advocating. They should be empowered to have the advocacy with proper evidence. And so if they are included in research, clinical research for hepatitis B, HIV, they'll be in a better position to use those research findings as advocacy tools to improve the patient care. So with this, I think all that we do for the better of the patients, and therefore putting them at the forefront and listening to them and including their patient lived experience should be very considered in integration of hepatitis B into other existing programs. Thank you so much for giving me the opportunity.
Thank you so much, Kenneth. We really appreciate your insights and your emphasis on the importance of including people with lived experience at all stages of integration. So thank you so much. So now we will pass it on to Mr. Aguocha, who will present on leveraging HIV and hepatitis C models for Hep B integration in Nigeria. So Chukwemeka, I will pass it on to you.
Thank you so much, Beatrice. Can you hear me and can you see my screen?
Yeah,
Okay.
it is oh yes, perfect. There we go. Thank you so much.
Thank you. Good morning, good afternoon, good evening, depending on where you're reaching us from. As Beatrice mentioned, my name is Chukwemeka Aguocha, and I'm a program manager on the Hepatitis and COVID-19 Therapeutics program here at CHAI. I'd like to start by thanking the Hep B Foundation for this opportunity to showcase some work that we have done around integration across the two countries, Nigeria and Uganda. But before we start, we want to also just look at the Nigeria model, where we've done a lot of work around HCV, HIV integration, and say how can we take lessons from here in the area of hepatitis B. So yeah. But first of all, let's really understand what we mean by integration and what we mean by integration. Why is this actually very important? Kenneth had spoken about, the limited resources around the hepatitis landscape and need for integration, which is absolutely correct. But in additionally as well, we look at integration and understand, it gives the opportunity for a patient-centered care to management for hepatitis. And also it just takes you away from that one size fits all approach, really understand how do you tailor services to suit the respective population. And that takes us to that DSD models. And in fact, this presentation will also take us through different DSD models at the community and the facility as well. And then overall strengthens the healthcare system, also improves cost effectiveness in LMICs like Africa, sub-Saharan Africa, where we have limited resources, it's important to come up with strategies that can optimize the available resources and cumulatively from a hepatitis lens, this will actually help us to advance the hepatitis response in Africa as we move towards achieving universal healthcare coverage. When we think about integration, we look at it from maybe one angle in terms of treatment availability, but integration spans beyond that. It's an end-to-end approach, looking at it from the point from preventive services down to treatment, care, and monitoring services. So we just look at approaches for integration across the different layers of the care cascade. For prevention services, we think about integrated messaging around awareness creation. How do we have, messaging around HIV, hepatitis, and syphilis, and also in terms of birth dose vaccine, as you are aware, Africa has been found to contribute 60% of growing hepatitis infections globally, and a lot of these infections are from mother to child transmission. So what this means is potentially the regular system of vaccine delivery may not be actually quite potent. So to think about innovative integrated approaches to vaccine delivery, ones around the MNCH platform and delivery wards. Moving to case finding, we talk about integrated hepatitis testing for different populations. Remember, we mentioned the DSD models. So what this means is thinking about how do you approach case finding from an integrated lens for the PLHIV in ANC clinics, in SRH services, and also looking at other primary healthcare services as well. I'm moving to diagnosis, which is one of the areas that jumps out when we talk about integration. But before we go into, molecular testing, we take a step back to look at integrated screening strategies. There's growing discussion around the triple test kits. So think about integrated testing in ANC, even for PWIDs. Talk about self-testing, reflex testing, just to say we have that early case finding, bearing in mind that hepatitis, if not detected early and largely asymptomatic, can progress to liver cancers. And secondly, there's the molecular near point of care platforms for multiplex testing, which provides an opportunity for integration. And lastly, around the treatment piece, to ensure that at one point we get different treatment options for the services for HIV, for HBV, for HCV, at the area of the clinics. These services are actually very available. So integration is not just on one lens, but it runs across the different layers of the care cascade. I'm also moving beyond the care cascade. Also think about integration from a point of, resource mobilization, having sustainable financing to say how do we also integrate hepatitis services into like insurance systems, donor funding, to ensure that patients who have comorbidities benefit. The interesting point here is hepatitis is not just domiciled in one population like the PLHIV, cuts across pregnant women, cuts across PLHIV, PWIDs, other populations. So what this means is there are pockets of areas you can think about, integrating resources to drive the response. There has been a lot of policy documents, policy pieces to drive integration, and the WHO has done a good job to, share the different strategic documents, to guide these conversations. But then we keep seeing challenges, with piloting the integrated approach. There's demand generation challenges, which we have seen consistently, with stigma around the HIV patients. So what this means is, people accessing care in the HIV clinics may be stigmatized as having HIV. Also, we've seen health system readiness, which is quite weak. In a case where a typical healthcare system in Nigeria, where we have one at the PhD level, when we have one healthcare worker, the question is how many services can the person provide at that time? And then the near point of care services also are limited, and it's important to ramp up availability to drive integration. And there is low case of evidence of integrated systems in LMICs. But we're happy to share with you, two models, one in Nigeria and another one, as I mentioned earlier, my colleague will share in Uganda. Speaking about Nigeria, as we know, is one of the most populous countries in Africa, with over 200 million persons, and we also contribute 30% to the Africa hepatitis burden. So what this means is we're able to drive down the infection rates in Nigeria, would have a significant transformational impact in sub-Saharan Africa. And with 16 million persons living with hepatitis B and 2 million with C, it causes a strong call for action. So the map in the middle, in the right there, you see the Nasarawa state jumps out right in the middle of the map in blue. Some other surrounding states will also show a high burden. But speaking about Nasarawa specifically, we've seen the high prevalence positivity rates of as much as 19% in the hospitalized patients. But despite this high burden, one thing that comes out is the unawareness, which is quite sad, because a lot of people are walking around with this infection and unaware of this burden, and continue to see ongoing transmission. However, the state government had taken the front seat to drive the response in Nasarawa, and I've come up with an admission strategy with child support working across four steps: plan wisely, test smart, treat all, not cure all, yes, and prevent new cases, with the PLHIV prioritized in the first phase of this work. And the ultimate goal is to see that we link all infected patients to curative treatments. Now, deploying this strategy is important to really understand and share with you what the initial challenges were and how we're able to address these challenges. I mean, we can't really overemphasize the gap with healthcare knowledge on managing viral hepatitis, limited awareness. And also in the ART clinics as well, sometimes there's absence of testing for hepatitis, as either for new patients, new enrollees, or routine testing. There's also limited access to RNS services or treatment services. And then, like I mentioned, unawareness continues to constitute a huge gap. And in cases where services are available, the high burden of cost, catastrophic expenditure continues to, inhibit access to these services. So driving this response, the first step was to create that enabling framework to allow for the public health approach to be implemented in the ART clinics, and that's by reviewing the policy guidelines to accommodate this public health approach, and encouraging tax shifting and centralized care to the secondary healthcare facilities, reducing the burden and wait time to see the specialists. Developing and deploying data reporting tools, and also coming up with targeted mechanisms to reach the PLHIV cohorts, considering that they're actually within the area. And at the time of this activity, we're just coming from the pandemic, so there's a lot of community level activities going on. So it was important to mobilize or integrate with the HIV program on how to reach the community level patients, and we use the ART default trackers. And I'll be speaking about this in the next couple of slides. So the study we'll be sharing with you was done across 4 ART facilities in general hospitals, Kiana, Awe, Wamba, and Doma, which are all spread across the regions in Nasarawa. It was 30 months duration. And the idea was ascertain the uptake of HCV screening, diagnosis, and treatment services amongst the PLHIV, and review the linkage to care components across the HCV cascade to really understand, how much progress and coverage has been achieved. Selection criteria, it had to be an ART facility, a high volume site, and with available diagnostic capacity, which was through the integration of HCV on the Global Kinespa platform. So really, it was more like, this service was provided for this to happen. The indicators that were looked at were around HCV antibody testing, linkage to care and uptake of HCV RNA test, And so this provided how to cut across the care cascade. Screening with HCV antibody rapid test, complementary testing with HCV RNA using the Finespa platform, and treatment with the sofosbuvir, daclastazvir, phenotypic direct-acting antiviral. So permit me to share with you, the first point of the integration was to really review the patient flow at the ART site to understand, okay, even if a patient comes in to access ART services, what is the flow looking like when the client comes in? And we see the client coming in, goes to the medical records, meets with the triage nurse for a review. Now, after meeting the triage nurse, depends on the patient's the outcome from the meeting with the nurse. There are two pathways. Patient either goes to get a refill from the pharmacy or is processed to see the erratic clinician. And after any of these pathways, patient exits. So you can see the type 1 patients are the refill patients, type 2 are the clinicians. But new clients coming into the facility, we see that they get tested, they are assigned, the unique ID, have a review by the triage nurse, meets with the erratic clinician, and also continues within erratic care. So looking at this patient flow, it identified strategic points for integration, which were, right after testing and before leaving, the facility at the point of, drug pickup. So in the case whereby if we miss testing this patient at point 1, we can retest at point 2, because the patient was expected to present the results of the test at point 2 before exiting the facility. Recall that I had mentioned earlier that while we had this study going on, we're just coming out of the pandemic. So we had a lot of patients access community care. So we have a fourth category of patients who are the community clients. And this category of clients, we leverage what we call the HIV defaulter tracker, who is responsible for identifying clients requiring HIV services, but we layered on HCV services into their package of interventions, having trained this defaulter tracker to be able to concretely test, screen for HCV, conduct reflex testing, and follow up with treatment services. So this defaulter tracker reviews the client entry records to identify patients who are lacking across the cascade and on any of the services, and then goes to the community, identify the patient, and provide that service. So these were the points for integration across the 4 patient types. And we see the results at the end of this 30-month period. We see we were able to we had 4,000 patients enrolled in care in these 4 facilities. Antibody tests were conducted for about 70% of them, which we found we had positivity rates of 11%. And from those who accessed RNA testing, confirmed that 60% of those who were exposed were actually confirmed infected. It was quite a high number. And have close to 80% placed on treatment, and we had 8% treatment completion rates across these 4 facilities. I would mention here that these resources, to drive these interventions, government has given some commitment around funding for use for procuring commodities, for these services. And this graph just shows us, it's the spread across, those who got facility level care and community level care. So you see to the graph to my left to say, at the time we started the screenings, services, we saw an equal amount of patients receiving facility and community care. But as we progress across the cascade, there was increased preference for community services. As you can see, as on the left, the bar for community continues to increase as we go down to the care cascade. And looking at it from a facility lens, we can see that GH Kiana had 100% facility services, while we saw treatment services occurring at the community in Grand Hospital Wamba. it was just interesting to see these different dynamics across the 4 sites. This just gives you an idea of the treatment cascade in each of the facilities to show where we had the highest positives. And from looking at the graph, we see that General Hospital Doma had the highest number of positive patients, while General Hospital Kiana had the least amount of positive patients. We went further in just conduct some patient interviews to really understand what could be potential barriers to HCV, access to care and recommendations and with the key success factors. And we realized that, across both facility and community, it's important to have that service availability. Financing was also another barrier that we saw, and also awareness. In terms of impacting access, we also saw service availability and costs were significant barriers, which tied to what we see, on the first graph which I mentioned. Interestingly, having effective counseling services were fundamental to improving adherence and ultimately treatment outcomes. And recommendations were the need for increased investments to reach more of the population, and also to ensure we have service delivery available and increase awareness. So what lessons have we learned in this approach? One is integrated service delivery is fundamental to ensuring maximizing resources, and also ensuring that patients receive optimal services either across community and facility. There's a strong community piece, having a stakeholder collaboration, and it also strengthens the healthcare system. This capacity of healthcare workers to provide a holistic package of care for their patients confidently, and of course informs programming and can be replicated across different settings and different disease areas like we have mentioned here for HBV, HIV integration as well. So really we can say it's a very successful strategy to enriching HIV clients, and the critical step in thinking about microelimination within LMICs. So at this point, I'll pass on to my colleague, Emmanuel, to speak about opportunities for integration in Uganda. So Emmanuel, over.
Yeah, thank you, Chukwemeka. And I think I'm very privileged to come after you and Kenneth. In a way, I feel you've already summarized most of what I would have said. I think in the next few minutes, I'll share with you our Ugandan experience and the lessons that Kenneth and Chukwemeka have shared still applies greatly to my presentation. I think maybe we can go to the next slide. So I will start by the fact that Uganda is a high burden country for hepatitis, one of the highest in Africa. We have an estimated population of about 4.1% of the population living with the hepatitis, that's chronic hepatitis B. We do not know, of course, the current burden of hepatitis C. My presentation will focus on hepatitis B and specifically elimination of vertical transmission. So overall, Uganda is estimated to be having about 2 million people living with hepatitis, and a significant proportion of this population is that of pregnant women. If we base on routine health data that we get through DHIS2, about 1.4% of pregnant women are diagnosed with hepatitis B, and almost 1% of children under 5 are also estimated to be having chronic hepatitis B. As you can see from that map, there is a disproportion in the distribution of hepatitis B in the country. The burden is higher in the northern, northeastern, and West Nile regions of the country, and fairly lower in the southern and southwestern regions of the country. However, individual districts within these regions with low prevalence may have much higher burden than the overall prevalence seen in the map you can see. And that the burden tends to be higher among people from socioeconomically disadvantaged populations. And we know in the country that the northern region had a long period of civil war, which contributes to part of the poverty in the region. Also, we know that a significant proportion of people living with hepatitis B also have HIV. As we can see that compared to the general population, about 4.7% of people living with HIV also have hepatitis B. So we could move on to the next slide. Yes. Chukwemeka has done a great job in showing us the different points at which we could integrate hepatitis-related services in our health services. However, just a moment. Yeah, sorry. So integration needs supportive frameworks and guidelines. And so I wanted to share with you what the government of Uganda has done over the years to provide that supportive environment for integration of services. So over the years, since around 2002, when we started the pentavalent program in the country, or immunization, the hepatitis space has evolved. And now we have, for example, the triple elimination strategic framework for HIV, syphilis, and hepatitis B that supports integration of Hep B, EVT, that's elimination of vertical transmission, into maternal and child healthcare points. We also have a national immunization strategy, which has within it provisions for timely Hep B birth dose. We also have an annual health sector performance report that reports on important indicators around hepatitis B related interventions. For example, the number of people screened for hepatitis B birth dose vaccination coverage, it provides for that. Including, we additionally have other important guidelines like the essential maternal and newborn care guidelines that supports screening for pregnant women during antenatal care, and linkage to hepatitis B prophylaxis, as well as Hep B birth dose vaccination. The consolidated HIV care guidelines, like you might have heard from Kenneth's presentation and from Chukwemeka's presentation, HIV infrastructure creates a very strong backbone for integration of hepatitis-related services, partly because of the shared similarities across these diseases. In Uganda, we also have a technical working group, or two technical working groups actually, one for hepatitis B in general, and then one for PMTCT or EMTCT that supports oversight for integrated service delivery. Next slide, please. Yes, so I wanted to delve deeper to speak a little more in terms of the different service delivery related points of integration in Uganda. And one of them is in terms of testing services for hepatitis B, which is very crucial because testing is really the point of entry for hepatitis B treatment. So hepatitis B testing in Uganda is available at various health facility levels. We have about 7 health facility levels in Uganda. But most importantly, health center 2, 3, 4, 5, which is a general hospital, a district hospital, regional referrals, and then national referral hospital. The expectation is that Hep B surface antigen screening should be available at all these health facility levels. Of course, this is not yet happening perfectly, but the existing framework support for that, including during community outreaches. When the health facility teams are conducting outreaches, the expectation is that if they are screening for HIV, then hepatitis should also be screened for. Most importantly is that these tests are also provided, or at least expected to be provided at mother-baby care points, for example, during antenatal care, as well as subsequent visits. Secondly is in terms of treatment monitoring. We know that hepatitis B also requires some significant degree of monitoring in the course of care, as well as for initiation of treatment. So we know that they along the way, patients will need complete blood counts, liver function tests, viral load tests to be done. We have a hub and spoke model laboratory system that was initially created for HIV TB related samples. Blood samples for especially viral load are picked from lower level health facilities, that's health facility level 2, 3, 4, and 5, and then transported to a hub, which is usually at regional level, before being taken to a central public health laboratories where viral load testing is done at national level. And then that is dispatched electronically to the system across the country. So leveraging on the existing HIV TB infrastructure, we are currently integrating viral load testing for hepatitis B, including for pregnant women. Next slide. Then in terms of, specifically in terms of triple elimination, focusing on hepatitis B EVT, there are also these various frameworks that I mentioned before have enabled that service delivery points are more functional now to provide hepatitis B elimination of vertical transmission related services at mother care points. I have shared with you on my right-hand side our national algorithm where all pregnant women coming for antenatal care are expected to be screened for hepatitis B, HIV, and syphilis. We have a dual kit for HIV and syphilis, and then a single kit for Hep B surface antigen. Pregnant women who test positive are expected then to be screened further, like I mentioned, for viral load, and the samples are being done centrally, leveraging on the hub and spoke model. And those who are eligible are then initiated on tenofovir prophylaxis. Most times this prophylaxis is accessible through ART clinics, that's antiretroviral clinics, which provide services for HIV as well. And they will be followed up by midwives at the different mother care points. So we can see the different levels at which integration is taking place, from screening to initiation of treatment and to follow up in terms of shared human resources, shared laboratory platforms, and shared points of care. Next slide, please. Next slide. Yes. So to share with you some more data in terms of how this has fared over the years, we are doing fairly well in terms of having the supportive frameworks in place and guidelines in place. These, of course, need strengthening, but because of the existing service delivery challenges in integration, we can see that generally HIV and syphilis services for pregnant women are faring a little much better. Nevertheless, if you see, for example, from the first graph that I share, in 2002, for example, we see that less than about a third of pregnant women who came for antenatal care at least once during the pregnancy received a screening for Hep B. While we see the number growing over the years. For example, this past year, over 1.1 million women actually were screened for hepatitis B, and it shows that the integration is greatly improving. And then in this year so far, we have over 860,000 women being screened for hepatitis B. So whereas there's still suboptimal coverage, where we have of the 1.9 million women attending ANC, less than 60 being screened compared to HIV and syphilis, this is actually improving. We have also a key challenge in terms of pregnant women who are eligible for treatment being linked to care. As you can see that less than 50% of women over the years who test positive for Hep B are actually linked to care. Key challenges exist across the country, most of them similar to what Chukwemeka shared in terms of supply chain challenges, insufficient funding to support commodities, as well as gaps in knowledge among healthcare workers to support integration and also ensure optimal availability of supplies and commodities. Next slide, please. So, key integration opportunities still exist in Uganda, and I believe in other African countries as well, to boost hepatitis testing, treatment, surveillance, and control. If we can strengthen hepatitis B integration through, for example, operationalizing one-stop centers for elimination of vertical transmission at mother-baby care points, we could have more women screened, those positive linked to care, and babies linked to timely hepatitis B birth dose. We also need to simplify the guidelines. Like you saw from my presentation, in Uganda, we still depend on viral load to initiate pregnant women to care, but this is not exactly functioning well. If along the way we could adjust our guidelines to give provision for a test and prophylaxis strategy, we may have more pregnant women with hepatitis receive care, and their babies eventually linked to birth dose prophylaxis. Another important aspect is that we need data in order to effectively monitor programs. In Uganda, in the past, we have leveraged the FEAR, the population HIV impact surveys to provide the national data for hepatitis that I shared, but we need to leverage this continuously, including the demographic health surveys, so that we have supportive data. Another important aspect is documentation. When you visit health facilities, a number of health facilities actually are providing some of these services, but then there are gaps in the documentation, which means what we see in the DHIS2 is not exactly reflective of the reality in the country. Lastly, we need to strengthen supply chain security to ensure that commodities are available for people, for the healthcare workers to use. In addition to the points that were discussed by Kenneth and by Chukwemeka in terms of involving communities in all these services. I think this is my last slide. Thank you.
Thank you so much to all of those speakers for excellent presentations, really, really fruitful points for discussion where I think that we can build off from in the next 10 minutes or so. So really appreciate that and encourage all of our participants to, if you have any questions, to put them in the chat box or the Q&A box, and we'll be sure to get them. I think that we had a couple of questions come in already, so thanks to those that have put them in. But just to get us started, really, really interesting conversations from both of you. I wonder if we could pick off from the Uganda experience really quickly. One thing that really struck me was the linkage to prophylaxis among mothers was low. Emmanuel, I wonder if you could speak to why that might be happening, and then if there's a way in which we might be able to bring in Kenneth from the community perspective to help also kind of clarify some of those points from the local level. So Emmanuel, if you could just speak to maybe some of the reasonings behind the linkage to care challenges and low prophylaxis among women.
Yes, I think there are a number of reasons, and Kenneth will talk from the community angle. But from the healthcare delivery side, one of them is the viral load. Like I mentioned, is that hepatitis B, women get screened for hepatitis B from almost the lowest health facility level, which is around health center 2 or 3. The samples for viral load have to be transported to the capital city, Kampala, where the Central Public Health Laboratories is. So there's that delay. And then, of course, delays on internally within CPHL, results actually produced very quickly. But by the time it gets down to the last point, and then the pregnant women get called for the care, most times they have already delivered. The second bit is in terms of stock out of commodities. And so we need availability of these cartridges. A number of times we have had stock outs in the country, and that makes access to viral load low. Lastly, it has been the complexities around the guidelines for hepatitis B. Because our previous guidelines require that pregnant women are managed from higher level facilities for hepatitis B. So they have to be referred if diagnosed from a health center 3, for example, upwards. And so they will unlikely actually move to the next level of care, which tends to be far off from wherever they might be. So those could be a few of the reasons. I might not have exhausted all. My colleague Veni is on call. I think she can come in and add other reasons as well as Kenneth.
Thank you.
Thank you, Manuel. You covered it well.
Go ahead, Vinny.
Now, thank you. I think Emmanuel has covered it well. Thank you.
Oh, thank you. A question as well to
Yeah.
follow up. Oh, sorry. Just one question
Yeah,
quick
I just
before we
wanted to
go.
add some.
Sorry, Ken.
I wanted to add some of the challenges probably that would also, yeah, so one of the other challenges that, thank you, Emma, for elaborating that, but one of the challenges that we also continuously see is that, let's be clear, currently when they are integrated in the HIV, not all have actually been integrated in all parts of the country. There are a few public health facilities that are doing that, but others are still, holding hepatitis B clinics like once a week. So imagine a pregnant mother has come today and it's not the clinic day for hepatitis B. So that also could be one of the challenges. But also, I think the capacity of health workers. We need to continuously carry out, education sessions with the community. I mean, the health workers, the midwives, so that actually they know what they are supposed to do for the pregnant mothers who have tested positive. Yeah, so those are some of the challenges, and yeah, over to you.
Thank you. Thank you so much for those responses. And as a follow-up to that, with the new WHO guidelines that were released this past March, there were some efforts to simplify the guidelines. I wonder if there is a planned update for Uganda. I know Nigeria just updated theirs, but wondering if that may impact the simplicity of care for mothers and help address some of these barriers as well.
Yes, Catherine, I may jump in here and the rest can add. Yes, actually, we are done with revising the guidelines, and several of the WHO recommendations have been incorporated into the guidelines. We have not yet adopted the test and prophylaxis, but I think within the guidelines, there are efforts to ensure that care is decentralized to, if possible, the lowest level facility. We know this will take some time before it's fully taken up, but that could partly impact care for pregnant women.
Thank you so much. In the question box, we also have some individuals echoing similar challenges with viral load and having to transport those to faraway sites, which delays the timing for individuals getting their test results. One question, since we're talking about this specifically, that came through, any way in Uganda to leverage gene expert sites for viral load testing? This individual says, I think these equipment are available and decentralized for TB. Is this something that can be leveraged for hepatitis B?
Yes, that's true. I think that there are efforts in the Ministry of Health to see the feasibility of leveraging the existing gene expert platforms. We have, I think, over 280 in the country of varying modules or capacity. However, I recently learned that it's not yet WHO pre-qualified. That might be quite a barrier in its being used for hepatitis B viral load, but those efforts are there.
Thank you. I wonder maybe, Chukwemeka, if you could maybe speak to that too, and if you've seen other modes of testing simplification in Nigeria. I know you did a lot with Hep C. Is there anything going on that was really beneficial on the testing side to work on that decentralization?
Yeah, thanks, Catherine. So for the Nigeria side, we're just beginning to, get the ground running in hepatitis B. We just finished, finalizing the guidelines, and looking forward to, doing a bit of piloting of the HBV DNA testing on a few genome platforms, maybe just on a very, very little small scale, just to demonstrate some feasibility. So we may not have clear, experience now, but I know that this is an area of big focus, going into next year for the country. And the plan is to deploy, a mixture of the test and treat strategy, where we don't have quick access to RNA testing, and also to look at settings where there are RNA testing to also see what plays out. But the big thing we're looking at is also to see find opportunities for introducing triple elimination, testing kits to improve, have integrated testing strategies at the ANC for easy case detection. Yeah, though we don't have individual pre-qualified kits, but to say how do we, have the mechanism happen, at the ANC facilities.
Thank you. And on that, we had a question come in about policy direction and influencing policy and advocacy. This was directed to Nigeria specifically, but I think that both of you may be able, or both countries can answer this question. What sort of ways might be beneficial from the community perspective to push for increased advocacy and influencing the policy around integration practices, and how we can improve upon that?
I could jump in.
Sure.
Yeah, thank you. Great question. Like I said in my presentation, I think involving the community in research on hepatitis B integration, HIV integration would actually provide, skills and data to use as advocacy tools to, advocate for policy changes. Quite often we see a lot of good research taking place in several countries, but the communities never get involved. And for me, that actually creates a gap, because at the end of the day, the researchers may not take on the advocacy as could have been if it was taken up by the communities that are impacted by the diseases that they are researching on. So involving these communities in the initial stages of research, planning, implementation, and also, they own up these, research findings, and that can actually work towards changing the policy shifts in our respective countries. So it's critical that we look at patients as not as objects, but as important, stakeholders in changing or driving the policy shifts in regard to hepatitis integration and other public health issues. Thank you.
Thank you, Kenneth. I couldn't agree more. Thank you so much. I know we're at time, but I want to offer the opportunity for any last comments or maybe recommendations for integration from all of your experiences. Maybe I'll start with Chukwemeka, if you have any last words of wisdom to provide to the audience.
Thanks, Katia. I mean, integration, it's actually the way to go. And as you have mentioned earlier, it can be overemphasized. But my last words would be that I think integration, not just from a service delivery point when it comes to diagnosis and treatment, but also across the whole spectrum. And think of it too in terms of resource mobilization. When you're looking at other programs like and PMCT interventions, SRH interventions, think of hepatitis opportunities for integrated hepatitis resources allocation, within those populations. Actually, PWIS, there are a lot of untapped populations that we can look at, and we could just have to think about how can we key into, those populations and stretch the available resources to cover hepatitis. That'll be my final words. Thank you.
Thank you so much. And over to colleagues in Uganda, if you have any last words of wisdom or thoughts that you would like to share with the audience about integration and strategies.
Yeah, I could jump in, but I would like to give a few minutes to Veni as well. I think we need champions. We need people who can be passionate enough, especially among healthcare workers, to push and support for integration at service delivery points. Behavior and attitude is important. Secondly, like among the CSOs, there's need for unity, unified advocacy messaging, so that we can reach far. Over to Vinny.
Thank you, Emmanuel. I think on my part, really the consideration of HIV positive HIV mothers. Many times they get left behind, and so we need to make sure that programs also reach them and that angle, and the opportunity of mother care points that have traditionally used antiviral therapy is a good one, because you're looking at health workers who have experience drugs and experience monitoring patients who are taking drugs. So, what I would like both about that, but I
Thank you, Vinny. It was a little hard to hear you, but I think we got some of your key points. Kenneth, any last words from you of wisdom?
Oh, sure. So effectively, scaling up hepatitis B integration in Africa will basically require a community-centered approach. And this community-centered approach should actually prioritize the patient voices and lived experiences if the integration efforts will be sustained. Thank you so much.
Thank you so much. And speaking to that, we would now like to just take a minute to discuss a call to action and some questions that we may not be able to answer today, but just to get us thinking about it into the next iteration of these conversation is thinking about what is needed at the community level to integrate these services. How can we work together to strengthen community and community advocacy, more financing and more awareness, for example? And how can we work to support each other in this way collaboratively? I think from today's session, there were major themes that really emerged for me in this conversation. The first is around the need for thinking about decentralization, and thinking about modes of which in which we can do integration. Maternal health, for example, or HIV services or immunization services were all mentioned as really key factors in ways in which we can integrate. Thinking about a unity message and how we move this forward and how we prioritize collectively, have healthcare worker champions who are also willing to take this up. As Emmanuel mentioned from his experiences in Uganda, which I think was really helpful, and also making sure the community is involved in the research and is a key stakeholder in moving this initiative forward, I think is really critical, because as we saw throughout the presentations, there were gaps in certain areas with linkage to care that the community may be able to help provide input on and uptake. So really great discussions all around. And I think this is really just the first step in a larger conversation that we will continue to be having together, and encourage you all to connect with us as we continue these conversations. And you can see the links to Beatrice's email on this slide and also our website here. But I want to thank all of our panelists and everyone participating in today's webinar. We hope that you found it as informative and valuable as I did, and we hope that this can impact your work on a daily basis related to hepatitis B elimination. Just a reminder, we will be sharing a recording of the webinar, and it will be emailed to anyone who registered, and we encourage you to connect with us as I said previously. Thank you all so much. We really appreciate your time and dedication to hepatitis B elimination and look forward to future collaborations and conversations just like this. Thanks, everyone.
Thank you, Catherine.
Thank you so much.
Thank you all.
Thank you
Have a
so
good rest of your
much.
day. Thank you.
Bye.
Bye. Bye.